Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
First, just a quick word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for more than a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricade.com/emcases to see how Metricade can make your scheduling fair, improve your sleep, and your performance. That's metricade.com/emcases.
This episode is brought to you by Paratus, your ultimate assistant for every emergency. Built on the trusted foundation of Easy Resus, Paratus brings you intelligent search, a complete library of procedures and protocols, and Atoms, your assistant to obtain the right information when seconds count. Discover Paratus today at paratusmedical.com/emcases and be ready for anything. There's a paradigm shift in stroke management that we need to know about. And we need to know about this massive change in the way we recognize and treat strokes for two reasons. One, because the nuanced decisions we make in the ED will significantly impact outcomes. And two, because stroke is one of the leading sources of medical legal action against ED physicians. The outcomes of patients with strokes depend on the specific diagnosis, the timing, and the pathway the patient is placed on. We need to get this right. And who better to help us understand this paradigm shift in stroke management than Katie Lynn, EM physician and stroke physician at Foothills in Calgary, and the new Deputy Director of EM Cases, woohoo! And North York General's walking encyclopedia of EM. We know him well. We all love him, Dr. Walter Himmel. Welcome, guys.
Such a pleasure to be here, Anton. Thanks for having me.
Thank you for having me. I'm looking forward to this afternoon.
Awesome. So to sort out when we need to activate a code stroke, to get the imaging and stroke team on board ASAP, to sort out the best imaging strategy, and to sort out the best acute treatment, let's hammer out two quick cases. Case one is a 74-year-old male, a fellow by the name of Winston Churchill. Maybe you've heard of him. He comes in with dense right hemiplegia and aphasia that started 3.5 hours ago. The second case is a 25-year-old female who just happens to be the wife of Justin Bieber, who also comes in 3.5 hours after symptom onset, but her clinical features are right facial and arm numbness and a right facial droop. Now, I'd like you to ask yourselves, how would you manage these two patients in the ED? Would you manage them differently? Are they both code stroke activations? Do they require the same imaging, different imaging? How quickly does the imaging need to be done? Do they require the same acute treatments? Lytics, endovascular therapy, neither, both? Do they require the same medications? ASA, clopidogrel, ticagrelor, dual antiplatelet therapy? And how quickly does all this need to happen? All right, so now that we have all these questions in our minds for these two cases, we can drop the paradigm shift in stroke care we've been hinting at. So this paradigm shift is really about how we categorize strokes and TIAs, and it's key to help us answer all the questions that I just asked you to think about. Katie, let's just start with, how should we categorize strokes with this new mindset or this new paradigm shift?
Well, historically, we've thought of strokes as major versus minor stroke. And this was based on a point-based National Institutes of Health stroke scale, or NIHSS score, which you may have heard of. NIHSS less than 5 was typically considered a minor stroke, while NIHSS 5 or greater was considered a major stroke. From a research and academic perspective, this made it easier to compare stroke severity across different patients who present with a different constellation of symptoms. basically a stroke severity standard that allows you to compare apples versus oranges and also track patients over time as the severity of their stroke changes or evolves. However, even a so-called minor stroke can be profoundly disabling for patients. For example, a patient with isolated aphasia might only have an NIHSS score of 3 or 4, categorizing them as a minor stroke. But I think we can all agree that a loss of language function is massively disabling for quality of life. So instead of thinking about strokes as simply major versus minor strokes as a binary system, we've started thinking in terms of disabling versus non-disabling strokes from a patient perspective.
All right, so we can sort of forget about minor versus major strokes. That's how we talked about strokes for years. Really, now it's about disabling versus non-disabling. Now, the problem with that idea or that paradigm shift is that it sounds kind of gray to me. So what might be disabling for one patient might not be for another patient. So, Katie, how do you decide if the stroke is disabling or non-disabling?
Great question, Anton. At an overarching level, I think the real question is, will these stroke symptoms fundamentally change the ability of this person to live independently or to live a quality of life that is meaningful to them? So disabling symptoms are the ones that prevent patients from being able to have that life independence or that constitute a significant loss to the quality of life if that stroke is left untreated. Symptoms that are impactful enough basically to justify the risks of undergoing those acute treatments. So this would include speech, motor, vision, and level of consciousness impairments largely. From a speech perspective, severe speech deficits, so severe aphasia or dysarthria, where language function and communication are functionally compromised. Severe motor deficits, especially loss of function to a dominant hand or arm, or loss of motor power to the legs, preventing the ability to walk independently. From a vision loss perspective, the loss of vision in one or both eyes in the form of amaurosis fugax, complete cortical blindness, or a dense hemifield visual loss. And low GCS, coma, impaired level of consciousness, or locked-in syndrome from a basilar artery occlusion or a brainstem stroke. These strokes can be particularly devastating, and they carry a high morbidity and mortality if untreated. These I would consider to be disabling deficits in the vast majority of patients. But you also have to consider the patient in front of you and potentially tailor that discussion too.
All right, yeah, this clears up things a little bit in terms of disabling versus non-disabling, but disabling is going to mean different things to different patients and their families. It depends on their age. Maybe one patient is a professional tennis player and the other patient likes to read books, and they're going to have very different definitions of what disabling is to them. So how do you have this discussion with patients and their families in terms of disabling versus non-disabling? We'll start with that. And then I want to ask, how's this actually going to guide your management decisions?
First and foremost, I discuss with the patient what their disability is and how they understand it. I quickly move on and say there are treatments available, but some treatments have significant side effects. So we need to determine how much of a problem you have right now. I think I can best describe this by giving you an example. About 3 months ago, I saw a person who was actually working in a hospital I work at as a clerk. Suddenly, she had difficulty speaking, and her right hand was a bit weak, as was her right foot. They brought her right down to emerge. About 15 minutes later, her speech was virtually back to normal. Her right hand felt a bit odd, but she could coordinate it well, but her right foot felt slightly weak. These are very minor features. She was able to stand, but felt a bit off. So here's what I said. I said, look, you've probably had a stroke. It's within 30 minutes. I'm going to have to probably send you to a nearby hospital where they can do EVT, endovascular thrombectomy, as well as TPA. How much are these symptoms troubling you? How much are they affecting your job? Or might they affect your job if it's exactly the same? How much will they affect your life? How much will they affect your walking? How much will they affect everything that's important to you? And she decided at that moment she probably could walk, she probably could get to work, her hand was getting better, and her speech was almost back to normal. So I spoke to a neurologist on the phone immediately, had the same discussion. And I said, listen, I want to transfer this patient for CT, CTA, thrombolytics. He says, well, how disabling is it to the patient? So I went back and spoke to the patient again, and we just weren't that sure. So here's somewhere where you can't be sure. Now, had she been retired and 70 years of age, she may have accepted her symptoms as being extremely mild. If she was 20 years of age and a medical student or a university student with a whole life in front of her, she may have said, listen, I can't spend the rest of my life like this. And at 55 or 60, it's hard to be sure. So what I ask the patient is, will this affect your life? Will this affect your job? Will this affect your functioning? Will this affect your ability to have a useful, meaning life that you enjoy? Almost will say yes. Then I say, here's the options. There are some risks. You've got to weigh the potential harms and the potential benefits. But I must say, if the only symptom is some sensory loss and they're otherwise fine, that's a no-brainer. It's easy. If they've got profound paresis and can't get dressed or walk or have to use a cane, that's pretty easy. That's a big deal. But with these subtle things, more than sensory findings, a hint of weakness, a hint of difficulty with speech, that's where it's joint decision-making. There is some equipoise there.
Yeah, it's pretty subtle, hey? Dr. Lin, in your experience on the stroke team, do you find yourself getting stuck on that first stage of deciding whether it's disabling or not disabling? Because as I hinted at, this is going to dictate the entire pathway that your patient's going to take. Do you have any tips or tricks about trying to get to that answer in an efficient way?
Great question, because you're weighing wanting to make a carefully considered decision for the patient in front of you against the time critical nature of coming to a decision so we can move forward with care for this patient. I think about patients that kind of fall into two different categories, right? There's the patient who comes in, they are aphasic or so altered or so symptomatic or so critically ill that they can't speak for themselves. And then there's the patients who are affected but still able to communicate with you. And I have a bit of a different approach for each of these two patient populations. So for the first patient population, they're too sick to make that decision for themselves. I really do try whenever possible, if they have family members, alternate decision makers, to be able to have that conversation and explain exactly what Walter has gone through, basically expressing to those family members and alternate decision makers that I might be the medical expert, I can help walk them through our options, but they're the expert on the patient's wishes. And that's where I think we bring our two perspectives together to make the best decision possible for this patient.
Ooh, that's good. I like that. Describing yourself as the expert to help make decisions about what to do next, but they're the experts in terms of, deciding how disabling it is for them.
Always, because those alternate decision makers and family members are the ones who know this person day in, day out before they had their stroke event. They give me such valuable information about what the baseline function of that patient is. And I think that's a really important part of the management piece that we often forget about. Now, we don't always have that luxury, right? So sometimes there is no collateral history available. Sometimes it's not immediately available. Maybe family's out of town or inaccessible. In those cases, I think we default back to what would a reasonable person want under these same circumstances based on the information I have available for me. And then I try and make the decision that gives me the most options at the end of the day. So if this patient is within a treatment window, it is what I would consider to be a disabling symptom and the patient cannot communicate for themselves, I'm going to go ahead and proceed with treatment if appropriate, because that leaves me with the most options at the end of the day for the next step. If, on the other hand, I'm dealing with a patient who is fully capable of communicating for themselves, as Walter had mentioned, his patient was, then I really do think that being able to have that conversation with that person and saying, look, if we don't treat your symptoms, this is the most likely outcome. If we do treat your symptoms, then there's a potential we could improve your symptoms, but it does come at a risk. And that risk with IV thrombolysis, for example, is about 3 to 5% risk of symptomatic intracranial hemorrhage. Is that a risk that would be acceptable for you based on the symptoms that you have and how much they affect your life? And I will again offer to kind of help walk them through that together, the options ahead of them, but using them as an expert in their own value system.
Fantastic. So the very first step in our pathway, we're actually going to have an EM cases stroke algorithm in the show notes. The very first step, again, is figuring out whether they have a disabling stroke or a non-disabling stroke. And as you can hear from our conversation, it's not so simple. But now we're hopefully armed with some great tools, tips, and tricks to have that discussion and be able to come to an efficient conclusion, whether it's disabling or non-disabling. Most patients, it's probably going to be relatively obvious, but there's cases where the patient can't talk for themselves, the family's not available, or there's patients like Walter's patient where they're kind of on the borderline, or their clinical condition might be changing, every few minutes as they improve. And then you have to kind of redefine whether the patient's disabled or not disabled. So that's, again, our first step of our sort of algorithm or pathway. Next in our algorithm, which again we'll have on beautiful display in the show notes, is whether or not the patient was last seen normal within a 24-hour time window. And sometimes it's not clear when the onset of stroke was. So Katie, could you just clarify why the last seen normal under 24 hours is important for time-based treatments?
Absolutely. So last seen normal defines the maximum time period where that brain could be ischemic. So last seen normal means last seen normal. When was the last time the patient was actually seen at their normal neurologic baseline? For patients with witnessed onset strokes, that's usually pretty easy. It's when the symptoms were witnessed to have started. But for many of our patients, as you've alluded to, they may have unwitnessed onset strokes. And the last seen normal time helps us to identify that maximum potential ischemic time. And we know now that the stroke must have occurred at some point after that last seen normal time. Acute stroke reperfusion treatments have been proven to work for patients within a 24-hour period from last seen normal. But the further out that patient is from their stroke onset time, the less effective those treatments become, and the more important it is to select the right candidates who have salvageable brain tissue, both because of the costs of treatment itself and also because the risk of hemorrhagic transformation increases with increasing ischemic time. So that's why it's so important to have that last known normal time.
Before we get into the different time windows, the 24-hour mark, Walter, what evidence is that based on? Why 24 hours? I mean, why not 48 hours or why not 12 hours? Why is it up to 24 hours that's so important?
Around 2015, there were the first successful published studies at endovascular thrombectomy. And in 2018, 2019, there were 3 further studies published. And every one of them looked at thrombectomies up to 24 hours after the event. And the evidence is quite clear. In well-chosen patients, well-evaluated, who meet criteria, thrombectomy up to 24 hours after the stroke began can improve outcomes dramatically. So basically, it's based on 3 massive studies conducted in North America and in Europe. That's where the 24 hours comes from.
So when you say highly selected patients, we're going to get into what that means. But could you just give us a sense of the percentage of patients who present with stroke to the emergency department that are within 24 hours that do receive specialized treatments like lytics or EVT? Not just, okay, we'll admit you to hospital and put you on some antiplatelets or a DOAC or what have you. What percentage of patients actually become eligible? Just so that we have a sense of who we're talking about and what percentage of patients will actually receive these treatments. Walter, do you have any numbers there?
I do, actually. It's been looked at, and it's very specific to country, continent, city, and all these factors. So I've got good news and bad news. If you look at thrombolytics throughout North America overall in patients with strokes, all strokes, it's about 10% of patients get thrombolytics. That might be on the high side. In terms of EVT, it depends who you talk to. When you speak to EVT neurosurgeons, they're going to tell you it's 10 to 15% of patients with strokes. When you talk to community neurologists and look at what the evidence is, it's a bit depressing. Probably somewhere between 8 to 12% of patients with strokes will end up with EVT if available. There's many reasons for that. So that's the number. So what am I saying? I'm saying approximately 80% of patients with strokes, maybe 75% of patients with strokes, do not get thrombolytics and do not get EVT. That's pessimistic and that's optimistic. Our job as emergency doctors is for those 20% of patients who are candidates, We've got to identify them, act fast, make the appropriate arrangements.
Some of that is because of delays to presentation. So sometimes patients will end up coming to our doors outside of an acute thrombolytic or endovascular treatment window. Some of that is going to be eligibility based as well. So we can really only offer endovascular therapy to large vessel occlusion strokes, which are going to be somewhere in the range of maybe 10 to 20% of the strokes that we see.
Fantastic. So I think it's really important to know that it's about 20-25% of patients who are actually eligible for these treatments. And so the majority of patients with stroke, unfortunately, aren't eligible and won't have a chance to get benefit from these treatments. And I think that's an important thing to also convey to families, because I think there might be a bit of a myth out there that in terms of the lay public, they think that there's these emergency treatments for stroke that are miraculous treatments that everyone gets and can cure their stroke. And so I think those are good numbers to know and, if necessary, to communicate with patients and families.
If I can make two comments further. Number one, you're absolutely right. A lot of patients come in wanting their clot busters, and they're often told by people who deliver them, you're going to get a clot buster. So that can be a very difficult conversation when they realize it might not be appropriate for them. Secondly, every patient needs an investigation. All patients have treatment available to prevent another stroke and so forth. So there's still treatments, there's still investigations, they're all essential. Even though 15 to 20% get EVT or thrombolytics, 100% get investigations and treatment. And we're the guys who get that going.
Couldn't agree more. I want to switch gears a little bit and talk about wake-up strokes, because we are going to come back now to this time from last seen normal and within 24 hours and more about timing. And it gets a bit confusing when we talk about wake-up strokes, and the treatment and management path for patients with wake-up strokes is a little bit more complicated. So, Katie, what about wake-up strokes? Why do we care if a stroke is a wake-up stroke?
Walter mentioned the 3 big trials that really help to extend that time window for endovascular therapy out to 24 hours, Extend IA, Dawn, and Diffuse 3. If you look at the actual data, the majority of the patients who received that extended time window treatment were wake-up stroke patients. So what is a wake-up stroke? A wake-up stroke is one in which a patient goes to sleep neurologically normal, that is their last seen normal time, but then they wake up with their stroke symptoms already present. So we know that that stroke must have occurred at some point during their sleep, but we don't know exactly when because the patient was unconscious when it happened. However, there are physiologic studies when we look at the literature that suggest that there's certain diurnal cycles to your cortisol, your blood pressure, your physiologic parameters. So often an hour, 2 hours, or even 3 hours before you wake up, your body starts to spike its cortisol levels in preparation for waking up. You start to see a rise in your blood pressure. And there's a theory that potentially that is when a lot of these wake-up strokes actually occur, is shortly before the actual wake-up event. And so when we look at these patients who come in with their wake-up strokes, often their imaging may actually look like the brain imaging of a patient who's coming in relatively early in their stroke period. Even though that patient may have gone to bed 8, 9, 10 hours ago, their brain looks like the stroke may only be a few hours old. This is why we care about wake-up strokes, because the eligibility for treatment might be a little bit more accessible for some of these wake-up patients.
So now that we understand what last seen normal is and we understand what a wake-up stroke is, what is the difference in terms of the pathway that that patient's going to go on? And how does it make it more complex if they're a wake-up stroke?
So remember, last seen normal time is when that patient was last seen at their neurologic normal. That's irrespective of whether or not they were a wake-up stroke, right? It's the last time we know for sure that that patient was stroke-free. If the patient had a witnessed onset stroke and then went to bed and then tried to sleep off their symptoms and woke up with their stroke, that's not a wake-up stroke. That's a patient who had a witnessed onset stroke who's late in the window. I know that their ischemia time is really quite long, and the likelihood we're going to be intervening is a lot lower. If, on the other hand, the patient yesterday went to bed and was at their neurologic normal, their last seen normal time is when they went to bed. And then they woke up with their symptoms. That's a wake-up stroke patient. The difference is sometimes in terms of where you're working, what the protocols are for these wake-up patients versus non-wake-up patients. Because a wake-up patient, we don't actually know exactly how long their ischemic time is. It could be really short, or they could have had a stroke shortly after they went to bed. So there's a lot more uncertainty in that wake-up stroke population compared to the patients who have a witnessed onset stroke in terms of the ischemia time. So if I'm working at my center, any patient who has less than 24 hours of disabling symptoms, we treat as a stat stroke. We proceed down our code stroke pathway. But if you're at a community site, or when I'm doing my consults to our rural centers, it might change the order of operations. Rather than rushing that patient into an EVT-capable site, we might try and get some imaging for that patient to know what we're dealing with and whether or not they're eligible before we commit to a really long transport and mobilization of a lot of resources. But wake-up strokes just have a higher probability of being potentially still salvageable and potentially still treatable because, again, we don't know exactly how long that ischemic time has been. Could be really short within window, could be really long outside of window. So it just becomes more important to expedite imaging in those wake-up patients.
Great. So bottom line is the wake-up patients, we really need to expedite their care. The pitfall then would be if they're a wake-up patient that, let's say they went to sleep 15 hours ago and then they present and then they wake up and then they present, 3 or 4 hours after they wake up, rather than think, oh, this is close to the 24-hour mark and there's no way they're going to be eligible for anything. It's the opposite. We should be really advocating for those patients to get rapid imaging, which will help determine whether they're eligible for any of these advanced treatments. Because with a wake-up stroke, as opposed to just last seen normal, they're actually more likely to be eligible.
That's right. Yeah. If I've got my stroke hat on and I know a patient had witnessed onset stroke getting close to that 24-hour mark, I'm a lot less excited about the possibility of treatment because that patient's a lot less likely to be eligible. Versus if they are close to that 24-hour mark, but they were a wake-up stroke, I'm still thinking we could potentially intervene. So I'm not slowing any of my decision-making down. I still want that expedited decision-making, especially for imaging, so I can select the patients who are going to benefit from late window treatment.
And now a message from one of our sponsors. Are you an emergency physician looking for an exciting opportunity? Cornwall Hospital is hiring motivated ER docs to join their dynamic team. With over 50,000 visits a year, you'll see a wide variety of pathologies in a fast-paced, supportive environment. Your colleagues and consultants are always ready and willing to back you up. Cornwall, Ontario is a hidden gem on the St. Lawrence River, offering waterfront access, outdoor activities, and a small city charm. All within an hour's drive from Ottawa and Montreal. Join their family at Cornwall Community Hospital, and once you're there, you'll never look back. For more information, please visit www.cornwallhospital.ca and click on Join Our Team, Physician Recruitment, or call 613-938-4240, extension 2227. I want to talk more specifically about time windows for stroke. Patients in the 0 to 4.5 hour time window from symptom onset may be eligible for thrombolysis, and some of those patients may be eligible for thrombolysis and EVT. For the EVT part, it's if there's a large vessel occlusion present. Patients in the 4.5 to 6 hour time window are no longer eligible for IV thrombolysis, but are still eligible for EVT, again, if they have a large vessel occlusion seen on CT angiogram. In this 4.5 to 6 hour time window, they don't require any imaging beyond the CT angiogram for treatment selection. Then there's the patients from 6 hours to 24-hour time window, and these are considered, quote, late window strokes, where advanced imaging like CT perfusion and MRI are typically done by the stroke team at the stroke center, and then they decide from there whether those patients may be eligible for endovascular treatment. So again, 0 to 4.5 hours, IV lytics. Some of those patients may be eligible also for EVT if they have a large vessel occlusion on CT angiogram. From 4.5 to 6 hours, they're no longer eligible for thrombolysis. If they have a large vessel occlusion on CT angiogram, they may be eligible for EVT. And then from 6 to 24 hours, only if there's a large vessel occlusion on CT angiogram and they have certain features on advanced imaging like CT perfusion and MRI, some of those patients will then be eligible for EVT. So that's our basic division of time windows in terms of how we're going to be treating the patient and how we're going to image the patient. But of course, it's not so simple because it depends on geography. It depends where you work. And geography will dictate some of the specifics of your stroke pathway. Particularly, again, the timing of and the location of CT and CT angiogram. So, Katie, you work in a tertiary stroke center, and Walter, you work at a large community hospital without a stroke team. So let's start with Katie.
So as you mentioned, I work at a comprehensive stroke center, and to be honest, that actually simplifies my decision-making in these cases. All patients who present within 24 hours of last seen normal with a disabling deficit result in a code stroke activation. And that includes a stat CT and CTA, as well as stroke team attendance at the bedside. I think it's a much more difficult decision for my colleagues who work at non-stroke centers. And I often assist with those decisions when I'm covering stroke call or transport call.
All right. So actually, Katie, could you tell us the kind of conversations you have with patients in rural centers? So let's say they're at least by land or air, they're at least, let's say, 3 hours from a stroke center. And then we'll talk to Walter about a large community hospital that's just within a few minutes of a stroke center. So let's speak to the rural folks out there. What kind of decision-making do they need to make in terms of image now and then send, or send and they'll do the imaging at the stroke center?
Great question. There's a couple of contextual things that I keep in mind for these conversations, and there's a number of clinical things that I keep in mind. On the contextual side, what I want to know is what is the transport time to get to the closest CT, and what is the transport time to get to the closest comprehensive stroke center. Those transport times I'm going to fold into the potential stroke onset to treatment time in terms of my considerations. It also depends on how quickly do I think we could actually get a CT done and uploaded for me to review from that rural site. Sometimes you have a site where they don't have 24-hour access to CT scan. Maybe they have to call in a tech. The turnaround time is going to be really high. If this patient has significant deficits, and I think they could have eligibility for treatment, even within that transport time, I might be more inclined to just get them on the road and rolling so that I can get them to a center where we can get that imaging a lot faster and make those decisions once they hit the door. In terms of the clinical side of things, the information that's really helpful for me to have from my rural colleagues, there's 4 pieces of info that if you have it on the initial call, it helps to expedite our conversation and decision-making. The first is, when is that last seen normal time? I really want to know, when do we start the clock on our time window? 2 is, what are the specific deficits that this patient has? And especially if they have those disabling deficits, describe them for me. How bad are they? Let me know if these are disabling deficits that we need to expedite treatment for. The third is whether or not this patient has thrombolytic contraindications. So are they actively anticoagulated? Do they have a concurrent trauma? Do they have a significant bleeding history? Am I worried about any structural issues inside the brain, like previous brain tumors or intracranial hemorrhages? That can be really helpful to know in advance what our options are going to be. And finally, a sense of what the goals of care and pre-morbid status for this patient is, because I'm not going to make this patient better than they were before they had their stroke. And if this is looking like a devastating stroke in a patient who had a very poor pre-morbid status or a goals of care that would not dictate aggressive therapy, then that's the point in time where I push the pause button and say we should probably have a family conversation before we transport this patient really far away from their family, from their home community, if this is potentially going to be a terminal life event.
I love that. So when you're on the phone as a stroke team specialist, the 4 things you want to know are last seen normal, what deficits do they have to determine whether it's disabling or not, their bleeding risk, do they have contraindications to thrombolysis, et cetera, and their goals of care and pre-morbid status. I love it. So, Walter, let's talk about how you're going to decide about Image Now at your center and then send to the stroke center, or just send to the stroke center and they do all the imaging and thrombolysis and whatever they're going to do. You work at North York General, where I work as well. It's a very large community hospital, and we have a stroke center about 10, 15 minutes down the road. So that's a specific situation as well. Walter, what do you do?
Well, because our center does not do EVT and does not give thrombolytics, it's actually surprisingly simple. Once I've decided the patient has a disabling stroke, and once we've agreed in discussion they want to be treated, there's 2 time periods: under 6 hours, more than 6 hours. If it's more than 6 hours, I do not transfer them to a stroke center for a CT/CTA. I do it. If it's under 6 hours, it's quite different in my hospital in Toronto. If it's under 6 hours, they can usually get to a stroke center within 20 or 30 minutes. I activate a code stroke. So under 6 hours, here's what a code stroke is at my hospital. No CT scan, no CTA. Call a stroke neurologist, call the paramedics, transfer the patient immediately. Now, there's one minimal exception to that. Let's say it's 5 hours and 50 minutes or 5 hours and 45 minutes. At that point, they're not going to make it to the stroke center in less than 6 hours from the event. So at 5 hours and 45 minutes, I may do the CT and the CTA. So if you don't give thrombolytics and you don't do thrombectomy over 6 hours, at least in Toronto, in my center, we do the CT/CTA. Less than 6 hours, we transfer immediately, and I'll tell you why. That patient, if it's under 4.5 hours, will get thrombolytics, and the patients under 6 hours who get EVT are different from the patients who get EVT after 6 hours. They're very different. Under 6 hours, time is really of the essence. After 6 hours, time is still of the essence, but not quite that much of the essence for reasons we can get into later. So under 6 hours, I transfer it out investigation. Over 6 hours, I do the CT/CTA.
Fantastic. So for the listeners out there, I'd like you to think about where you work, what's available to you, and your determination of whether you're going to Image Now and send, or just send first, or just call your stroke team and let them do everything. That's going to definitely depend on where you work, what your resources are, and how close the stroke center is to you.
Now, certainly, I got to say, there is a third group of doctors that we can't ignore. There are many medium-sized hospitals in smaller communities where the emerge doctor gives TPA. And the reason they do it is they're so far from the stroke center, they've become their little stroke center all on their own for giving TPA. So if you work in a hospital where you are the neurologist and you give TPA, then if it's 2 or 2.5 hours, you will not transfer them to a stroke center. Depending on the system you've established, you may do the CT scan all on your own. You may go ahead and give the thrombolytic on your own and then transfer for a CTA if you can't do it yourself. So it's very hospital specific.
We have a system in Alberta of the stroke network, essentially, where we have the comprehensive stroke centers, which can provide EVT therapy. We also have support from stroke neurology, and we have IR capability, as well as neurosurgery and ICU. But then we also have our primary stroke centers, which are trained to deliver IV thrombolysis in an acute phase. And really, your only imaging that you need for IV thrombolysis is a CT, a dry CT, a non-contrast CT. You don't need the fancy imaging before you give IV thrombolysis. You just need a plain CT head to rule out hemorrhage and your assessment of the patient to rule out contraindications. And then that patient, within a 4.5-hour time window of stroke, is eligible for IV thrombolysis, even if you're going to ship them on to a bigger stroke center for their CTA and definitive treatment.
That's a great clarification. So there's actually kind of 4 groups in terms of location. There's you work in a stroke center, in which case you activate or code stroke anytime within the 24-hour window. Then you've got rural, which you may or may not have a CT available to you fast enough. If you have a plain CT very fast, you can do the CT and even thrombolyze. If you don't have access to CTA and you have to call in a tech, you're probably going to be transporting that patient to the stroke center without doing anything. If you work in a large community hospital near a stroke center, When it's under 6 hours, you'll probably just ship them and not do any imaging at your place. If it's after 6 hours, you might do some imaging at your place and then speak to the stroke neurologist. And then if you're in a smaller hospital, community hospital, you may do a quick plain CT. And if it's within 4.5 hours, you can thrombolize and then ship them out.
That's perfect. So know your system. Once you know your system, you'll be so much more relaxed because you'll know exactly what to do. If you don't know your system, it is not a nice day.
Absolutely. Sometimes it's possible to predict which patients will have a large vessel occlusion on CTA from their presentation alone. And this is important because the patients who might have a large vessel occlusion are the ones who are most likely to benefit from our emergency interventions. So, Walter, I understand that there's about 8 different tools that we can use. There's the Cincinnati tool, there's the VAN tool, there's the Act Fast tool, and that, depending on where you work, different centers will use different tools to help predict clinically which patients might have a large vessel occlusion on CTA and then be amenable to emergency treatments. So, Walter, could you just review for us what the key aspects of these tools are and approximately what their sensitivity is in terms of predicting a large vessel occlusion?
Okay, so I'm going to give you a somewhat long answer, but it should be clear. Under 6 hours, you don't use these rules. Under 6 hours, the question is the stroke disabling or not? If it's disabling, they get transferred to a stroke center under 6 hours. Between 6 and 24 hours, as we've been discussing, thrombectomy is still available, but thrombectomy is for people with large vessel occlusions. If you can transfer a patient to a stroke center within 20 or 30 minutes, if that's not a problem, or if you're in a stroke center, they're going to get a CT-CTA immediately as a standard of care. But let's say transfer is difficult. Let's say there are many logistic problems. Now you've got to ask yourself, what's the probability this patient has a large vessel occlusion? Because transfer is a big deal and very difficult. So here's what you do. First of all, a patient has to have weakness of one arm or the other arm. If they do, that means the probability of a middle cerebral artery large vessel occlusion is high. I don't mean a bit of weakness, I mean dramatic weakness. You lift up their arm and it falls down to the bed. If they've got dramatic weakness of one arm, then you move on and you want to determine, is this cortical, a large vessel stroke, or is it just a small lacunar infarct, which can also give you devastating weakness? So how do you distinguish a lacunar infarct in a small vessel from a large vessel stroke giving you cortical findings? Here's what you do. If the person is dysphasic or aphasic or can't follow orders or can't understand, that means they've got a cortical stroke. So a patient with weakness of the right arm and dysphasia or aphasia or can't be able to understand, has cortical findings, that patient has a high probability of a large vessel stroke. That patient must be managed aggressively and transferred aggressively. If the patient has weakness of their left arm, and they have neglect, they cannot cross the midline, they have hemianopsia, the probability of a large vessel occlusion is again high. And the moment you've decided the probability of a large vessel occlusion, giving you cortical symptoms is high, they are treated aggressively. You get on the phone immediately and speak to a stroke center to determine if they can get aggressive intervention with a CT-CTA. Now, that being said, there's 2 CTAs, quite frankly. There's one you're going to get within minutes, and one you're going to get within hours. And that's how I use this rule. If they have a cortical stroke with arm weakness and aphasia or neglect, or they can't cross the midline with their eyes, they're going to get a CTA somehow within minutes because the large vessel occlusion is likely and thrombectomy may be helpful. On the other hand, if they don't have arm weakness of the arm, and they don't have aphasia, and they don't have neglect, this is probably not a large vessel occlusion. You're still going to get a CTA, but it might not be as mandatory to get it within minutes because the likelihood of a large vessel occlusion there is low. That being said, this is a compromised solution in a system that can't do everything. It's a compromised solution. And if you're in a community where you can't do everything, then you're going to really do your best if it's a large vessel occlusion. And if it's not, you will do your best, but not as aggressively. It may not be possible. That being said, the sensitivity of these tests are probably in the range of about 80 to 90%. And there have been cases clearly where the patient has some weakness of the arm, does not have terrible aphasia, does not have terrible neglect, and still has a large vessel occlusion. If possible, in the ideal world, you want to get a CTA quickly if they've got disabling stroke. But where it's not possible, or sort of possible, you use these rules. And if they've got neglect, if they've got dysphasia, if they've got profound weakness of an arm, you're going to push really hard for aggressive therapy.
If I might expand on things as well, I completely agree. There's a whole bunch of clinical scoring tools that were designed to try and pick up large vessel occlusions before you get to imaging. And depending on where you work, there might be different scores that you've heard of. The VAN score, the ACT FAST score, the Cincinnati Stroke Screening Tool, the LAMS score. All of these scores are trying to get at that holy grail question of what is the likelihood that this patient has a large vessel occlusion stroke that could be amenable to endovascular therapy. And it's especially important in a geographically separated or distributed population like we have in Canada, because you don't want to be transporting a bunch of patients into a comprehensive stroke center that never needed to be transported in the first place because they didn't have a large vessel occlusion stroke. And so these scores across the board have a reasonable sensitivity, as Walter mentioned, of 80 to 90%. Their specificity is a lot lower, which means even if you score high on this tool, does not necessarily mean that you have a large vessel occlusion stroke, but it means that your likelihood of having a large vessel occlusion stroke is a lot higher, and therefore mobilizing those resources for transport, expediting your imaging, getting the teams going quickly might help to provide treatment in a timely fashion for these patients. So that's what the scoring tools are for. Doesn't really matter which of those tools, if you look at the literature, you end up using, but having some sort of structured tool can be really helpful for communicating with your stroke specialists, for organizing transports.
All right, not easy decisions, but I think we've hopefully helped listeners in terms of how to assess whether a patient might have a large vessel occlusion, which will hopefully help them act fast. Also, bring across the point that when in doubt, pick up the phone to your stroke neurologist.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES.
I want to talk a little bit more about goals of care and assessing pre-morbid status, because this is going to help dictate your pathway as well for your stroke patient. We've already touched on when it comes to disabling versus non-disabling paradigm, and that patients and families need to be involved in that decision-making. Then there's the goals of care that are super important for stroke patients. So Katie, how do you discuss goals of care with patients and families?
I think this is so important because it really helps us to structure how we manage each individual case for the patient in front of us. And I have two kind of versions of my goals of care discussion, depending on how much time I have. If I'm in an acute stroke, code stroke scenario, I don't have a lot of time to have that conversation. Whereas if I've got a non-time critical condition, I can spend that time with the family and really explore those nuances. In an acute time critical emergency, we have to have that conversation relatively quickly in order to move forward with care. So my general approach for my critically ill patients or time critical patients, and this is applicable to stroke and beyond, I start by identifying who my decision maker is going to be, whether that's the patient or an alternate decision maker, a family member, a loved one, a friend, whoever it might be. And then I use a 4-part approach to really help to get me to that conversation fairly quickly. I start by signposting that this is going to be an important conversation for us to have. And I may have to have that conversation pretty quickly with them because the treatment is going to be time critical. I also summarize for the patient or their family what is going on so that we're all on the same page. So I might say to them, this is a really important conversation I'm going to have with you. We need to make this decision quickly because it's time sensitive for me to give that treatment to your loved one or to the patient. Here's what's going on. Your loved one has a really big stroke. This stroke has left them with the symptoms that you're seeing right now. We have a couple of options and paths that we can take next, but it's going to be really important that you and I work together to make the right decision for what matters most for this person. This is where I start to align myself and really highlight the fact that I am going to be the medical expert. I can help walk them through those decisions so they're not going to be alone on that journey, but they themselves are the experts in their own values, what matters most to the patient or the loved one. And I really need to understand that piece in order to make the right judgment call for that patient. After we've had a chance to lay down the groundwork, that's where I start to explore the options and the paths before us. And the way that I like to frame this is really to try and simplify the complex decision-making down to the essentials of what that patient or family member needs to know to choose based on their values. So for me, I usually will outline what that option is. So option number 1, we proceed with treatment. Because of this big stroke, we have the opportunity to provide a clot-busting medication or to take this patient to a procedure where we can try and go in and take that clot out. The most likely scenario, if we do this procedure, is that we might improve their symptoms. I don't know that we're going to be able to get them back to completely stroke-free status, but we can probably improve their disability from where it is right now. The best case scenario is that we're treating them fast enough that I can reverse their symptoms entirely. The worst case scenario is that by doing this treatment, we introduce some risk and I might actually cause things to worsen if we cause a bleed. The risk of bleed is X%, depending on what the patient factors are or the imaging factors are. So that's path number 1. Option number 2, we don't treat. We don't take for this specialized procedure, but we can manage their blood pressure. We can manage their medications really carefully to try and minimize the damage of their stroke. The most likely scenario, if we choose not to do this aggressive treatment, is that your loved one will continue to have these disabilities or these symptoms, that those symptoms may even worsen a little bit over time. The best case scenario is that in 6 months or 12 months, sometimes stroke symptoms can recover over time. I just don't know how much of that recovery we'll see. Worst case scenario is that if we don't treat, this stroke may become worse as the swelling starts to set in, as the stroke continues to grow, and your loved one could become more sick, and this may actually be a life-ending event as well. And we need to discuss which of those options might be most acceptable to your loved one. Will they accept the risk of this treatment if it has a chance of improving their symptoms, but knowing that there might be a slight risk of worsening things? On the flip side, would they accept living with fairly significant disability? So there might be some big strokes where I can speak with families and say, if I don't treat, likely the outcome is that your loved one will pass away, will die from this stroke. If I do treat, I may be able to save their life, but likely they'll be left with a big disability. Is that disability something that they would be willing to live with, that would be within their value set for quality of life? That's the worst case scenario, is that we save someone's life, but they end up incredibly profoundly disabled. Is that acceptable? And that's going to be tailored a bit towards each patient that I see based on what I think the likely outcomes are going to be. But that's the general approach that I take, is to start by signposting, to summarize, to bring us to the same page, to align myself with patients and their loved ones so that they know it's really important to hear their voice and what matters to them and their value sets, And then I simplify the paths in front of us to try and help guide them through what I think, based on what I've heard, is going to be the most appropriate treatment.
Wow, I hope if I ever have a stroke that I'll be right next to Foothills and that you're on call for the stroke team. Walter, anything to add in tips or tricks or anything, communication tips you have in terms of goal of care with patients and their families?
Yeah, I think I emphasize, depending on what their life is like, the following factors. The ability to go back to work, that's a big issue. Equally more important issue, often in research, is the ability to remain at home and function at home versus being transferred to a long-term institution. These are factors I discuss with the family. And certainly, if there's a theoretical probability they can prove sufficiently to stay home, I'll make that clear. If there's a theoretical probability they may go back to work, I'll make that clear. And a massive stroke, where I believe in my soul this person's in serious trouble, their prognosis is bleak, then I'll really have a discussion. I may preserve their life for a while, but there's a good probability they're going to be extremely disabled long term. So I discuss those three issues: the risk of long-term disability in massive strokes, and the benefit in less massive strokes, theoretically, of being able to remain home, which is a big issue, or be able to go back to work and look after themselves.
All right, maybe in an ideal world, Katie will be on call for the stroke team and Walter will be my emergency physician when I have my stroke.
A true pan-Canadian code stroke.
That's right. There we go. So that's all about goals of care. We also need to determine what their pre-morbid status is when we're making these decisions. Sometimes that can be tricky as well, actually. So Katie, how do you know what a patient's pre-morbid status is? Like, what kind of questions do you ask? How do you figure out quickly what their pre-morbid status is? And how does that help to guide your treatment decisions?
The reason we care about pre-morbid status is because it impacts the decision about whether or not to proceed with treatment. I'm never going to make a patient better than they were before their stroke. So if they had an impaired quality of life before the stroke event, there's a really good chance we could leave them with an intolerable degree of suffering if we do proceed with treatment. So my tip for quickly getting a sense of pre-morbid status within even a minute or two, it just involves two questions. The first is, where does the patient live? Do they live independently in their own home? Do they live in assisted living? Do they require long-term care with 24/7 nursing availability? And the second question is, how do they normally mobilize? Are they completely independent? Do they use an aid like a walker or a wheelchair? Or are they fully bedbound and dependent on others, again, for full-time care? So those are the two questions to quickly get at pre-morbid status. Where does the patient live? And how do they normally mobilize?
Fantastic. I want to shift gears now and talk about the evidence for lytics. So I remember a day when it was very controversial whether or not to give lytics in the first place, because different people interpreted the original NINS trial very differently. Walter, even when we were discussing it back then years ago, you were, I think, generally a proponent of lytics. At that point, it was within 3 hours, I think it was, for the NINS trial. Some of the EBM people, they argue that the NINS trial really wasn't very good evidence. And since then, they've never really replicated the NINS trial. So we still don't really know whether lytics actually really work or not. So the reason why I'm asking Walter this rather than Katie is Katie does have a bit of a bias because she works on a stroke team. So she might have a bit of a bias towards lytics. So let's go with Walter. Walter, what's your take on the evidence for lytics within the 4.5 time window that now is guideline recommended?
That's a very tough question. I'll answer it in this manner. Almost all internists, virtually all stroke neurologists, virtually every continent on planet Earth, and virtually every country has accepted that, on the balance, thrombolytics given to the appropriate patient in the appropriate time overall leads to improvement in functioning. That's my definitive opinion. Now, if you go back to history, back to the 1990s, and read all the newspaper articles, you'll find out there was probably 1 or 2 people and a cohort of 10 others who were the naysayers. And to this very moment, I think they still feel the same way about it. That's history. TPA has been accepted as an effective therapy. As well, with improved imaging, with improved accessibility, with MRIs and CTs and CTAs, with a greater ability to go with the tissue diagnosis, it's only going to get better. The accepted treatment right now, but almost everybody is that the thrombolytics are effective. In their worst case scenario, thrombolytics given within 3 hours will help at least 11 to 15% of patients will be significantly better. And probably 1 in 3 will have some improvement. No one's having this argument anymore. 1 in 3 will have significant improvement, and 1 in 10 will have dramatic improvement. By dramatic, I mean they'll end up with what's called a modified Ratkins score of 0 or 1. 0 means normal, and 1 means a trivial deficit. 1 in 11 people, about 11%, rather than having significant deficits, will have almost no deficit or 0 deficit. That's generally accepted. And there's been tons of meta-analysis and meta-analysis. No one's investigating this anymore. That's the current status. And I don't think we're going back. To the small number of people who don't agree with this, they're entitled to their views, and I understand their viewpoint. But generally speaking, thrombolytics are helpful. It's more important to emphasize that thrombolytics under 90 minutes are extremely helpful. Thrombolytics between 90 minutes and 180 are helpful, but less helpful. And 3 to 4.5 hours helpful, but much less helpful. We have to act fast and get moving to be experts in this area.
I want to talk further about lytics and then talk about TPA versus TNK. So, Katie, do you recommend TPA or TNK as your thrombolytic of choice? I mean, I understand that TNK is a bit faster to give, and I've read that it might even achieve better results. Is there a better drug, TPA or TNK, or is it just kind of the pharmaceutical companies trying to fight it out, and it depends who you read?
We're certainly seeing over the last number of years in stroke that there's been a transition towards tenecteplase or TNK instead of TPA or alteplase. There's a couple of reasons for this. There have been a number of large trials that have come out over the last couple of years, including a Canadian-run trial called the ACT Quicker trial, which looked at TNK versus TPA and has identified non-inferiority of TNK in terms of overall outcomes. There's even some smaller European trials and international trials that seemed to show a slight advantage in terms of reperfusion rates and safety profile for tenecteplase or TNK. The advantages of TNK or tenecteplase are largely logistical. So because it's given as a single bolus instead of the bolus plus infusion calculations that needed to be done for alteplase, there is some literature showing there's less medication administration and dosing errors, which is good for our patients and good for our overall outcomes. It's also helpful in centers where you might be looking at transport. So instead of having to set up a pump for IV infusion during transport for a patient who's receiving thrombolytics but going to another center for endovascular therapy, for example, you can just give that bolus pre-departure, and then you don't have to worry about tying up another IV line and another pump, which can have lots of issues in terms of equipment and drug administration issues. So logistically, tenecteplase is simpler to give. It has the same indications and contraindications as alteplase used to, and we're seeing largely a transition more towards tenecteplase. But having said that, it depends a bit on what your center has access to, non-inferiority based on the literature.
All right, Katie, you had mentioned contraindications to lytics. I understand that those have actually changed over the years. And of course, we're all just going to look on our computers on what the contraindications are to TNK before we give them. But Walter, could you just update us on what the major changes and contraindications are for TNK?
Sure. TNK and TPA is being used in people with strokes over the age of 80. Being more than 80 is not a contraindication. For a while, there was a contraindication in patients who've had a previous stroke and who have diabetes. That is no longer a contraindication. And a lot of people with diabetes and strokes, there's a lot of people like that, not a contraindication. As far as warfarin goes, the INR should be under 1.7. Now, heparin, I'll talk about in a moment, and I'll talk about dabigatran and other direct oral anticoagulants. If you're on IV heparin, which almost nobody is anymore, you've got to be off it for 4 hours and have a normal PTT. At that point, you can give thrombolytics. As far as low molecular weight heparin goes, enoxaparin, fragments, stuff like that, the time is 24 hours. 24 hours since the last dose allows you to use TPA. Now, with direct oral anticoagulants, it's a bit different, actually. The only agreement on that for sure is more than 48 hours. More than 48 hours since your last dose of a direct oral anticoagulant, you can use thrombolytics. In terms of GI bleeds and trauma, you've got to use judgment. Originally, having had a GI bleed or a GU bleed in the previous 3 weeks was an absolute contraindication. Now they're relative contraindications. You've got to decide how big the bleed was, if it was treated, and use your judgment and so forth. In terms of severity of strokes, we are certainly using thrombolytics in patients with very major strokes, certainly up to National Institute of Heart Stroke score of 25. After that, probably not. You have to have a discussion. Those are actually the major changes. In terms of vascular abnormalities in the brain, if you've got an aneurysm less than 10 millimeters, less than a centimeter, that used to be a contraindication, no longer is. You've got to use your judgment. If you've got AV malformations not treated, that is a contraindication. And when it comes to tumors and so forth, it depends. Tumors like meningiomas are not contraindications. Vascular tumors probably are contraindications. So they've been loosened a lot, but they do require a fair amount of judgment. Now, in terms of eye surgery, if you've had a lens implant recently or cornea surgery, that is not a contraindication. If you've had retinal surgery, it may be a contraindication. So certainly over 80 is being used, with diabetes is being used, with anticoagulations is the time I've said, 24 hours for low molecular weight heparins, 48 hours for DOACs. We could go into it a lot further, but that's the big stuff.
I would just add that this is one of those high-risk medications that we're not giving very frequently, especially if you work at a rural site or peripheral site. So this should absolutely be a situation where ideally you have a protocol that you can refer to that lists out these contraindications. This is a perfect situation for a checklist just to make sure that we're hitting all of those important pieces and checking for all of those important components to contraindications. And a good resource is the Canadian Stroke Best Practice Recommendations, which is available for free online if you Google it. It's got the most up-to-date list of contraindications for guideline-based care.
And now a word from one of our sponsors, Paratus, the all-new emergency assistant. Paratus combines everything you loved about Easy Resus with powerful upgrades, just-in-time procedural guidance, stress-proof organization, and Atoms, the intelligent assistant that helps you find exactly what you need. Whether you're in the ER, on transport, or in the field, Paratus keeps you ready for anything. Learn more and start your free trial today at paratusmedical.com/emcases. That's PARATUS medical.com/emcases. I want to talk now about endovascular therapy and the evidence for it. So, Katie, what does the latest literature tell us about endovascular therapies? Can you just kind of summarize for us for EVT, mortality, functional outcomes, etc.?
Absolutely. So the initial landmark trials all came out in about 2015, were published together in the New England Journal of Medicine, establishing endovascular therapy, EVT, as standard of care for large vessel occlusions. Those initial rounds of EVT trials looked at EVT within a 6-hour window. The extended time window EVT trials that have come out since in 2018, 2019 have now extended our treatment time window out to potentially 24 hours. But as we get further and further out in that time window, the imaging factors become so much more important. And that's where in those extended time windows, we start needing some of our advanced imaging tools like multi-phase CT angiography, CT perfusion, or MRI. In general, across the board, the number needed to treat for EVT is about 4, no matter which of those meta-analyses you look at. So that means for every 1 in 4 patients you take with a large vessel occlusion and a devastating stroke, you will improve their outcomes quite significantly in a lot of cases.
Wow. A number needed to treat a 4. That's remarkable.
Yeah.
I didn't realize it was that good. I mean, there's very few things in medicine that we do that have a number needed to treat that good.
It is an unbelievable game changer. And I will tell you, Anton, that there's nothing quite like the feeling of taking a patient to the EVT suite who is paralyzed and aphasic and absolutely devastated by their stroke, being able to get in there, take the clot out, and on the table have a Lazarus effect where they can now speak with you and move their arm and they're back to where they were before their stroke. There's nothing quite like that feeling, but that's what this treatment gives us the ability to do.
So, considering that lytic therapy is still a little bit controversial and the outcomes are pretty good, you could argue, it sounds like EVT is so much better. Why wouldn't we just do EVT for everyone, no matter what time window they're in?
You raise a really good question. And this is actually an area of ongoing stroke research. It's been debated in the literature for the last number of years, and it's still undergoing some active trials. Within the stroke world, this is something that we call bridging therapy. So if you're taking a large vessel occlusion stroke patient to EVT, which of those patients do we need to bridge still with thrombolysis? And is there advantage to bridging with thrombolysis? And there's no clear consensus in the stroke literature yet on that question. But what we do know is there are still roles for IV thrombolysis, even when that patient goes on to EVT, for a couple of reasons. So one, sometimes we'll get into the EVT suite, we'll try and get into the vessel, and for whatever reason, we run into difficulties. Maybe there's an anatomic quirk of the blood vessel that makes it really hard to access. Maybe the clot is a lot denser than we initially anticipated, and it's very difficult to extract. In those cases, sometimes thrombolytic could have been helpful either for softening the clot or potentially even reperfusing the patient in the early stages while we're getting them transported in for EVT, especially in those long transport cases too. We're not delaying the possibility of reperfusion. Additionally, sometimes during the EVT procedure itself, we can embolize small pieces out distally. And perhaps in those cases, it would have been helpful to have thrombolytic on board because our EVT wires can only go so far. We can only access those proximal large vessels. Once the clot gets into those smaller vessels, we can't actually go after them anymore. It's at least not safely, right? We introduce more risk of puncturing the vessels, more risk of complication, or the vessel itself is smaller than our wire, so we just can't chase it. So still, for a lot of these reasons, our interventionalists, for the most part, still prefer to have IV thrombolytic on board, even when those patients are going on to EVT. We have a couple of recent trials demonstrating that outcomes overall seem to be better functionally if patients have thrombolysis before their EVT.
Fascinating. I want to talk a little bit more about EVT and exactly how it works to save brain tissue. I mean, on a very basic level, you're opening up the vessel and you get more blood flow. And so you're saving brain tissue, and then you've got your penumbra and you're kind of minimizing any more ischemia that's going to happen. Walter, is there anything more to EVT than that?
Well, that's a big field. So every stroke has 3 areas. The core, in which you have dead brain tissue that's gone, and that can be radiologically identified. It's got the penumbra. This is tissue which is hypoxic. It's not dead. It's causing clinical symptoms, and it's a penumbra that we're trying to save and prevent from becoming a core. And that's why you use thrombolytics, and that's why you do endovascular thrombectomy, to save the penumbra. And outside the penumbra, you've got normal brain tissue. The assumption is the following, and this is what's turning out. If you've got a significant defect, with a small core and a large penumbra, identified through imaging, you can have a massive benefit to the patient. And of course, the more ischemic the penumbra is, the faster you have to act and less success you're going to have. Now, some penumbras have tremendous collateral circulation. You can save these patients 18 to 24 hours, which is why they're doing EVT that late. Other penumbras have crummy collateral circulation. You won't do much. This is why imaging is very important, and we're going to talk about it. So it's all about the penumbra. And it's impossible with imaging to determine if a deficit is due strictly to dead brain tissue or dead brain tissue plus a penumbra, which is given clinical symptoms, which could be reversed. The penumbra is super important, and imaging will tell you more about the penumbra.
Closely related to the penumbra is blood pressure targets, because if our blood pressure goes too low, then that penumbra is going to become ischemic very quickly. If our blood pressure is too high, then we worry about causing a bleed, and we need to really titrate the blood pressure just right. We've always had this sort of permissive approach to hypertension during the treatment of acute strokes. It's been standard for years now, but I understand the evidence for this has changed recently. So, Walter, could you just go over for us the current best evidence recommendation for BP targets in acute ischemic stroke and which antihypertensive drug is best?
So this is very subtle. Think carefully. I mean, the worst thing is profound hypotension, man. Profound hypotension is the worst. Okay, here's what I do. Is this patient a candidate for thrombectomy? Is this patient going to get TPA, or are they not going to get a thrombectomy and not going to get TPA? Let's talk about the majority of patients, which basically is not TPA and not thrombectomy. The guidelines are still pretty remarkable, and this is going to shock most people. The guidelines say the following: if you're not a TPA candidate and you're not going to get a thrombectomy, you don't have to intervene in the first couple hours unless the pressure is more than 220 over 110 to 120. If their pressure is more than 220 over 110 to 120, and they're not going to get a thrombectomy, and they're not going to get TPA, you can wait for an hour or two and see if it starts to come down. Now, in practice, most people at that level of 220 over 110, 120 will give medication with the idea of bringing it down by about 10 to 20%. In plain words, down to a systolic of about 180 or 190. But you don't have to rush in the patient I just described. Now, over 6 to 12 hours, you'll bring their pressure down slowly. But certainly, there's no need to get that under 180. No need to do so in patients who are not worsening and not candidates for further aggressive therapy. If they're candidates for TPA or candidates for EVT, endovascular thrombectomy, it's different. If they're candidates for TPA, you definitely want to get their pressure under 180 over 110. That's still pretty high. Under 180 over 110, and then once you begin TPA, under 180 over 105. And certainly it's permissible in these patients to get them down to a systolic between 160, 170, 180. But what is very, very clear is there's absolutely no need, even with thrombolysis, no need to get the systolic under 140. It's unhelpful and may be harmful. So thrombolytic candidates, definitely start to get them under 180 or under 110 and aim for getting them down to a systolic of about 180 or 170 or 160, but no more aggressive than that. It's not a rush. The numbers for EVT is the same. Before they do EVT, they really want the pressure to be less than 180 over 105, and preferably a systolic in the range of 170, 160, 150. But no less than that. The worst thing you want to do is drop the pressure dramatically. Because hypotension in a hypoxic area with a narrow artery is much worse. Now, what are the two drugs? In Canada, we tend to use lepreseline. Labetalol is most commonly used. In the States, they have a drug called nicardipine, which they use to lower pressure. It's more easily controlled, it's more effective, and it's probably safer. So the drugs to get familiar with if you're Canadian are labetalol and apresilene, used occasionally if labetalol fails, but it's basically labetalol in Canada. And in the USA, depending where you're at, it's labetalol or nicardipine. They're both given intravenously and they're both titrated. I want to add one thing. Do not confuse intracranial hemorrhage with an ischemic stroke. Do not confuse intracranial hemorrhage with an ischemic stroke. The targets are completely different. With intracranial hemorrhage, you definitely want the pressure to be systolic under 180 and possibly down to 140.
Just to expand on what Walter has said too, the reason that reperfusion changes our blood pressure targets is because once we go and open up that blocked vessel, we now introduce a bunch of blood flow to an area of the brain that's been ischemically damaged. And that's going to increase the risk of hemorrhage. So that's why we lower that blood pressure target down in patients who are eligible and going to proceed to reperfusion as compared to the patients who we are not going to reperfuse. We often let them cerebrally auto-regulate a little bit on that higher side until a little later when we start to slowly bring their blood pressures down.
Fantastic. I want to talk more about imaging. We've already talked about how plain CT is great for ruling out bleeds, and we want to get that quickly because if it's a bleed, we're going down a whole other path. We've talked about how CTA of the head and neck is great for determining whether someone has a large vessel occlusion or not, which is going to help dictate whether they're eligible for EVT. And we've talked a little bit about so-called advanced imaging like CT perfusion, MRI, for example, which might help the stroke team decide whether the patient's eligible for EVT in that 6 to 24-hour window. I want to talk a little bit more about CTA findings because we're sending patients off for CTAs all the time where I work, and I get a report back, and I'm not really sure what to make of the report. I'm not sure which findings are really the important ones, which ones aren't in terms of stroke management. So, Walter, could you just go over for us what the important findings that we need to look out for on that CTA report to help guide management?
Sure. Well, CTAs have certainly become very popular. And in fact, the number of CTAs done per emergency department per year has probably gone up 10-fold to 20-fold in the last 10, 15 years. So I know they have because I've looked at the figures. It's dramatic. Here's what you want to know when you do a CTA. Are your vessels completely normal? If not, do you have a occlusion or a stenosis? Do you have one in the vertebral arteries or the carotid arteries or intracranial? Because intracranial stenosis is also very important. Then you want to know, do you have a dissection of the vertebral artery or the carotid artery? Is the dissection in the neck or does it go into the brain? That's the next factor you want to know. The other lovely thing about CTAs, of course, is you can look at the aorta. Do you have an aortic dissection? Do you have clot in the aorta? Do you have a stenosis in your common carotid artery requiring endarterectomy at a later point? Those are bigger things. Vertebral artery stenosis or dissection, carotid artery stenosis or dissection, stenosis in the neck or stenosis in the brain, aortic disease. And of course, there's a whole host of weird diseases like fibromuscular dysplasia, AV malformations, multiple intracranial stenosis, vasospasm. Those are all the things you're going to know from CTAs. It's a dramatically wonderful investigation, which can be done quickly.
And Katie, in terms of what you want to know on the stroke team, in terms of acute treatment of these patients, what are the key things you look for on the CTA?
So all the things that Walter had mentioned, I'm looking for on the CTA as well. So I'm looking for occlusions. I'm looking for severe stenoses. I'm looking for thrombus. I'm looking for dissections. I also am pairing that with the dry CT head part of the investigation as well to look at the extent of the stroke that we're dealing with. Because for me, it's also really important to know, is this stroke an established stroke? Is it already all core? Do I already see signs of early ischemic changes which help to guide me in terms of whether or not intervention is going to be helpful for this patient? Or is it so early that we're not seeing those early ischemic changes? And I think a lot of it could still be penumbra, where we can intervene on and the risk of hemorrhage will be relatively lower because that tissue is still perfusing. The other thing that I look for on CTAs, especially when I have access to multi-phase CTA, for example, is the quality of the collateral blood flow. So this is those extra vessels that start to kick in when you have a vascular occlusion in the intracranial arteries. When you block off blood flow to one part of the brain, there's collateral blood supply that can kick in to start taking over some of that perfusion pressure. But everyone's collateral blood supply is a little bit different. So somebody who is young, has no vascular risk factors, we often find they do not actually have very good collateral blood supply because their brain hasn't been exposed to decades of microischemic insults to force it to develop those backup systems. Whereas a patient who has those vascular risk factors, those kind of chronic factors like smoking or diabetes or hypertension, they may actually have a more robust collateral blood supply. And the reason we care about those collaterals is because that dictates how quickly a stroke occurs. If you have a good, robust collateral blood supply, often the infarct happens a lot slower because you have this backup blood flow that's still providing some perfusion to the brain before it usually will fail after a number of hours to days even. Versus if you have someone who has very poor collateral blood supply, I know that stroke is going to progress quite fast, very quickly. So I don't have as much time before intervening. So that's what I look for as well, is that collateral blood supply and the quality of those collaterals.
Fantastic. We had just mentioned how wonderful CTA is and how it can give us so much information. The one pitfall that I've seen multiple times is we get back a CT-CTA that's perfectly clean and perfectly amazing. We have this patient who's had a stroke in front of us, and we think, oh, the CT-CTA is so perfect. This patient couldn't possibly require any urgent treatment or really isn't that sick, and you don't worry about them. What if we have a perfectly clean, normal CT-CTA, but clinically the patient still has a significant stroke? What do we do, and why is it important that we do the right thing, and specifically in these patients?
So you get your CT-CTA back, and there's no visible abnormality. This patient could still be having a stroke. It might just be occurring in a small blood vessel deeper in the brain. Typically, these are called lacunar strokes. And if you imagine, it's just an area of the brain where those neurons and their axons are so densely packed that a very small lesion can knock out a lot of function. It's essentially if you've created a traffic jam on a highway, right? We just don't see it yet on CT-CTA. We may not see it until later when we do the MRI or after the scar tissue is actually formed and become more visible on CT scan. So this patient could still have a stroke. In the back of our minds, we're always wondering in these cases, could this be a stroke mimic? Could it be one of those other conditions that looks like stroke? And that's why we're not seeing anything on the CT scan. So depending on what your local protocols are, what access you have to your specialist consultants, there are a couple of tips and tricks that we use at the bedside to help us distinguish between stroke versus mimics. We also sometimes have the capability to get advanced imaging like CT perfusion, for example, which can help us to kind of look in the right direction in those cases too. But I would say the bottom line is if you are in doubt and this patient is presenting acutely within a treatable time window, they have no contraindications to treatment, and they have disabling deficits, I would err on the side of treating as a stroke until proven otherwise, especially if they're eligible for treatments like IV thrombolysis. This is not a contraindication to lysing a patient.
Walter?
Everything Katie said, I agree with totally, but I want to make a few comments that once understood is life-changing. A large number of patients with strokes will have normal CTAs. They may have atherosclerosis, but no major occlusion. That is not exceptional. That is normal. The heart and the brain are very different. It's commonplace to get strokes with a relatively normal CTA. Secondly, and this is really important, there's two kinds of CTAs. There are two kinds of CTAs, and they're somewhat different. Once you get this, life is simpler. If you're investigating somebody for a transient ischemic attack, and you're looking for a carotid artery stenosis, which is surgically amenable, you're doing a straightforward, simple CTA, a good look at the arteries. If you're getting a CTA as part of a stroke protocol, most places do multiphasic CTAs, which includes your regular CTA that you're going to get for a TAA, and then immediately further imaging, look for delayed filling and venous filling. That's what Katie was talking about, the multiphasic CTAs to determine if you've got good collateral blood supply to the penumbra. So it's two CTAs, the stroke and the TA investigation CTA. Now, how does radiologists know what to do? Well, it's institutional specific, but generally speaking, if you order stroke CT CTA to be done immediately in the next 5, 10, 15 minutes, most places now are going to do CTA of the multiphasic type. If you're ordering CTA for investigation of a TAA, it's not going to be the next 15 minutes. It'll be done maybe in 3, 4, 5, 6, 7 hours. And some places, maybe a day or 2 days later, they're going to get a straightforward traditional CTA to look for stenosis in the neck or the brain. At that point, they're not worried about collateral circulation. So there's the CTA for strokes, EVT, thrombolysis, and the CTA for investigations of TA in minor strokes, which may require surgery later for endarterectomies. Those are the two kinds of CTAs. Once you get that, life is much simpler.
So one piece I just wanted to add on here is it's just a clinical pearl around communicating well with our radiology consultants to help them help us. I think it's really important, 2 pieces of information that our radiologists need to give us an accurate read on our CTs and our CTAs, because those occlusions can be quite subtle, especially if they're in those small vessels. So we really need to let our radiologists know when was that last seen normal time and what are the patient's deficits, because that helps them know what kind of ischemia they might be expecting based on the time frame. It also lets them know where to focus their search pattern when they're looking at the scans, especially for those smaller stroke occlusions. It can really give you a more accurate diagnosis on that read and lower that risk of false negatives.
I want to go back to our case of Winston Churchill. So he's our 74-year-old who presents with aphasia and hemiplegia at the 3.5-hour mark. In the ideal world, what is Mr. Churchill going to receive? Assuming that this is not 1956 or whenever he had his stroke, that this is 2025. How are you going to manage Mr. Churchill?
Yeah, so for the listeners out there, Winston Churchill actually famously had many, many strokes and TIAs over the course of his lifetime, and all of this, unfortunately, predates our modern reperfusion therapies. But if Winston Churchill had presented today in 2025, we can identify that he's presenting with a disabling stroke deficit within a 24-hour time window from last seen normal. He needs a code stroke activation. Depending on where you work, that may look a little bit different, but ultimately he needs stat imaging, ideally CT and CTA. He is within a 4.5-hour thrombolysis treatment window. So with his disabling deficits and eligibility for thrombolysis, he would be a candidate for receiving IV thrombolysis therapy. And if we identified a large vessel occlusion on CTA, then the next step would be transfer for endovascular therapy consideration.
All right, fantastic. Any last words of wisdom about stroke that you'd like to add before we wrap up? Walter?
Identifying a stroke as being disabled, not disabling, is crucial. Getting the history about weakness and vision neglect is crucial. The discussions are crucial. Know your system. When you know how your system operates, you'll be much more relaxed. And remember, there's 2 kinds of CTAs to use in different situations. Be clear on that, because if you click the wrong box in the wrong order, it's not going to go as well as it could otherwise. And also remember, it's the patient. When it comes to thrombolytics, it's the patient and the plain old-fashioned CT, which is still fabulous. You don't need a CTA to get thrombolytics. And also, if the CTA is normal, the patient's had a stroke, it's not a mimic, it's a stroke. Many of these patients have normal CTAs or abnormalities that are very, very subtle. It's very different than coronary angiography, so do not be surprised. Different kinds of CTAs, and normal CTA does not mean a normal patient.
Fantastic. And Katie, any last words of wisdom about stroke or disabling strokes in particular? The next podcast will be on non-disabling strokes. So words of wisdom for disabling strokes?
Remember the 4 key pieces of information that you can help gather to expedite that conversation you have with your stroke consultants. First, last seen normal time, and whether or not this was a wake-up stroke event. Second, are there disabling deficits present, as we've mentioned? Motor, speech, vision, level of consciousness, or locked in? Third, are there any thrombolytic contraindications present? And ideally, if you have some sort of protocol or checklists that you can work through to check these. And finally, fourth, the patient's goals of care and pre-morbid status.
Amazing. So in part 2, we're going to cover non-disabling strokes, imaging for patients with non-disabling strokes. We're going to talk about antiplatelet therapy options, which we didn't get to on this one. We'll talk about when to use DOACs in stroke. We'll talk more about stroke mimics, disposition decision-making of stroke, and state-of-the-art follow-up care for non-disabling strokes. And hopefully a lot more surprises for me and the audience. Thank you so much, Katie and Walter. I'm hoping that our audience out there will feel a lot more comfortable next time they have to treat a patient like Winston Churchill who presents with a disabling stroke.
Thank you. That was fun.
This has been a pleasure. Thanks for having us, Anton.
One last thing to let you know about, if you haven't heard already, that's coming down the pipe in the next few months. We've been working on my sort of dream come true for EM Cases, the EM Cases coaching app, which is a personal learning coach for anything and everything EM Cases that's ever been published. So if you want to brush up on, say, pediatrics or trauma or resuscitation or what have you, the app will set an individualized learning plan just for you based on the EM Cases podcast, summaries, videos, and quizzes, and give you feedback on your progress. We'll have all the details in the EM Cases newsletter, which you can sign up for by hitting the subscribe button on the website. All right, until next time. Take it easy.